Okay, folks. I think we should be just about ready to start now. First of all, can I welcome you all to Sector Connector. This is a forum that's been established to help link mental health voluntary community sector providers with the statutory sector, the NHS, local authorities, public health. And this is the second of our Sector Connector forums. Previously, the last one we did in the 3 separate CCG areas. So we had one for Brighton and Hove, one for East Sussex and one for West Sussex. And this morning we're doing things slightly differently. We're all together for the first 45 minutes. And then the second 45 minutes, we're going to go into breakout rooms. Now, if you've not already indicated which breakout room you want to go into, or if you want to change breakout rooms, could you please indicate in the chat or email Rebecca at healthwatchbrightonandhove.co.uk. And Rebecca is here helping us this morning. For the first 45 minutes, we've got 3 speakers. The theme this morning is about digital solutions. And I'm just getting a message saying that my camera is off, so excuse me while I try and fix that. In the meantime, I'll continue with just my dulcet voice. Yes, we've got 3 speakers this morning, and then we go into the breakout rooms. If you've got questions as they come up, could you enter them into the chat? My apologies, I seem to be having some IT issues. The other thing to mention at this stage is that the session is being recorded. So just so everyone knows that. What I'm going to do now is to go to Lester, if he's there, the first of our speakers. And if Lester hasn't joined us yet, then I'll go to Nathan, who lead us off. The theme this morning is about digital solutions. And what we're aiming to do is to finish up being able to suggest 3 or 4 key things that we think will help move that agenda along and pass those suggestions along to commissioners and other decision makers. Okay, could I hand over to either Lester or to Nathan to lead us off with the first presentation?
Yeah, I'm here, David. So shall I go first?
Yeah, please.
Okay, I'll share the screen. It says the host has disabled participant screen sharing. Does anyone want to?
Yeah, Rebecca, can you fix that, please?
No, Lester.
Okay, cool. Can you oh. Just excuse me a second. Can people see that, or do you want me to expand it?
It's fine.
Yeah, sure.
Fine, can see that.
Yeah, sure. Okay, I'll go back to the start. Okay, so yeah, it's very strange speaking to an abyss, isn't it? But I'll go for it. So this is an interesting piece of engagement work we did back in, or the data was collected back in June and July this year, which is an important context to bear in mind when we look at some of the findings. But the study was looking at the ways in which people accessed health and care services during the pandemic, and also looked at an important part about how people saw things bearing out in the future. So this piece of engagement was essentially a survey of 2,185 people across Sussex. It wasn't just Brighton and Hove, it was across Sussex. and consisted of a mixture of standard questionnaire forced response questions, but also some interesting open-ended questions and some follow-up conversations with people that had completed the survey, which really enabled us to go a little bit deeper into some of the findings that had come up in the survey. And we looked at experiences during the pandemic, so things like the services they've used, but also particularly focused on how or what their preferences were towards accessing services in the future, and a range of different services, things like GP outpatients, but also a couple of mental health ones, which I'll pull out later. And the data was analysed sort of in standard fashion, really looking at headline frequencies, but also we did some subgroup analysis looking at the differences by age, gender, sexual orientation, disability, and ethnicity. Disability one was particularly interesting because we broke that down further into those that reported in their own description of little disability and those that were affected a lot. And that some of those findings will come out as we progress. So straight into the headline findings. I think one of the striking findings for us was that 37% had delayed appointments despite having had an evident health or social care need. They'd chosen to delay these appointments during the pandemic, mostly due to either their condition they didn't think was serious enough, but also some other concerns around they were either shielding or they didn't want to catch coronavirus. Some didn't even think the NHS was open to seeing people for things like GP appointments, etc. And what was even more interesting in some ways was that people with disabilities we found were 4 times more likely to delay appointments, independent of their age, gender, ethnicity, and sexual orientation. So that's a particularly significant finding because we controlled for these other factors around age, gender, ethnicity, and sexual orientation. In terms of the appointments that had occurred during the time in which the data were collected, and I say that point because we would imagine if we did the survey now, these percentages would actually be higher than they are at the moment. But we found that 63% had some form of phone appointment, and then you can see a lower percentage had online, and an even lower percentage had video, and 35% had some form of face-to-face interaction. Obviously, people could have had more than one type of appointment, so that's why they don't add up to 100%. But what was interesting as well was that there was a high level of satisfaction for appointments by type of contact across the board. So whether they had a phone appointment, online or video appointment, there was a generally high level of satisfaction. I've just picked out one here with phone satisfaction where 80% were satisfied or very satisfied with these phone appointments. That's particularly significant because I think if we go right back to the first finding about the people that are delayed appointments, it does suggest that if they've been encouraged or felt as if they could go through with a remote appointment, then the likelihood is they may well be as equally satisfied as these other people that had had such an appointment. Okay, so these are for me the most interesting findings because it starts to look at people's preferences towards the future. The question actually asked them in literal sense, think about life after the pandemic, which back in June and July, I didn't think it would be that long, but life after the pandemic, think about, and we asked them whether they'd be happy, that was the actual word we used, to have a GP appointment in this first instance by phone, video, online, and not happy for any remote. In other words, not happy for phone, video, online, pretty well assumed to be face-to-face. I picked out these first two because they're the most common type of appointments. And you can see, looking at the GP, there's a high percentage of people that were happy to have a phone appointment, but about 1 in 5 were not happy for any form of remote appointment. And less interest really, or slightly less interest for video appointments and even less interest for online appointments. And for outpatients, the pattern is similar-ish in the sense that there was over half that were happy by phone, half by video, at least by online, but you'll note the higher percentage of people that were not happy for any remote appointment. And certainly looking at some of the open-ended comments and the follow-up conversations, this was due to the fact that they felt that an outpatient would offer some more specialist care, so they might think that they might lose something if they weren't able to see them face-to-face. Okay, so And these are two findings which I pulled out particularly for this presentation. Bear in mind that we looked at 15 different services, so I couldn't present them all here, but there are two here which are particularly relevant here for this session. So the first one was looking at sort of general emotional mental health support, including counselling and therapy. And the second one was more specialist care, I think, looking at long-standing and serious mental health conditions. And I think what's interesting here is, firstly, the parallels with the previous appointments in the least or the lower percentages preferring online consultations of this nature, a reasonable interest in phone and video, but not to the extent certainly of the GPs. But you'll notice in this final right-hand column, the interest that these people had, or the lack of interest they had for phone, video, online appointments. In other words, more likely or more preference towards face-to-face support. So 29.7% for the emotional and mental health, including counselling and therapy, not happy for any remote appointment. And then an even higher figure of 43.6% for those not happy for any remote appointment with long-standing and serious mental health conditions. So that's a really significant finding and hopefully of interest to today. Okay, so we're already at the conclusion. So I think overall, looking at the whole pattern of the data, we found that remote appointments are generally well received by some people, but certainly not all people, and certainly not all services, and certainly not all for particular conditions that may be warranted a face-to-face consultation. Most of the differences were seen by age and disabilities. So on the one hand, that means that there was no real significant differences by gender, sexual orientation, or ethnicity, which is again interesting. But what we found in terms of age was that younger people were generally happier to receive future appointments by the phone, video, and online compared to older people for a range of different services. So virtually all the 15 different services that we looked at, there was a pattern of younger people showing greater preference. Now, that's an important point as well, just to extend that, because I've used the word younger here because this was younger in the context of what was quite an aging population that answered the survey. So the average age was about 50 odd. So we found that younger people would be particularly around about typically sort of 30s, late 20s, etc. Now, to extend that evidence, we then worked with Young Health Watch, who did exactly the same survey among 13 to 24-year-olds. And they showed, similarly to us, that that population were much more keen on these type of remote appointments. So that does extend our evidence a bit. Although there were some interesting nuances around things like, particularly with young people, was the concern of privacy. How would they have that online conversation or phone conversation, perhaps when they're in their own house, etc. In terms of disabilities, people with disabilities were generally less happy with all of the remote options relative to those who were without disabilities. And it was especially more extreme for those affected a lot by their disability. So they were the least likely to want any form of remote appointment. In terms of the disability, it's also worth saying that for this presentation, we only, of the 2,185, we only received, I think, about 150 people that had described themselves as having a mental health condition. So it was quite difficult then to sort of break the data down any further than that in the way that I've done for the overall area of disability. Okay, so what does it mean for decision makers? Well, this is the final slide. So this is part of a much bigger document which we're using to flag some of our implications and recommendations. But I picked out three here today. First of all is the element of choice of appointments. So people were very keen on having a choice of phone, video, online, or face-to-face. And invariably, this choice was not given. In fact, I don't think we found hardly anyone who had the option of a phone or video online. It was more than likely stated that that's the appointment they would have. Bless you. And then the second point here is, I think with what I said earlier about the remote appointments generally favourable, but not certain or not the case for everyone, then I think that does support the idea of this hybrid model or blended approach of partially remote and partially face-to-face of health and care provision. And just to say that this term remote, it's worth saying that when I mean remote, I don't necessarily just mean digital, because for a lot of people, they were using landline phones as a form of remote consultation as well. And then the final point does indicate some of the work we're taking forward. And obviously this, this blended approach or hybrid model does depend on people having access to digital solutions for health and care provision. And given that this was an online survey, the actual element of digital exclusion would be probably far underestimated, because those people that were excluded probably wouldn't be able to fill out this survey. So that's worth bearing in mind. So on the back of that is the need to reduce digital exclusion. And the first part of that would be to map out what is going on, perhaps nationally, but also particularly important what's going on in Brighton and Hove locally. And that's been the impetus for a briefing paper, which I'm just sort of partway through doing at the moment, looking at what is the level of digital exclusion in Brighton? How do we measure that? What are the efforts that are being done to reduce digital exclusion, etc. Yeah, and that concludes where we are at the moment. So it does lead on to some ongoing work. Thank you.
Okay, thank you very much, Lester. And my apologies, folks. I seem to have quite a lot of tech issues this morning. But if we could lead now into our second presentation, and go to Beth.
Okay.
Thank you, Beth.
All right, give me a couple of seconds to share my screen. I have screen sharing disabled at the moment. If somebody could give me access to that, please.
You should have it now.
Okay, let's see. Ah, yeah, here we go. Thank you. Okay, so hello everyone, and apologies for my late arrival. I'm Beth Lawton, and I am the Chief Digital and Information Officer for Sussex Partnership. And so it was my team that led our digital response to COVID-19. So before we start, I thought it might be useful to talk about what I mean by digital, because well, I mean, you can get 10 people in a room and have 11 definitions of digital come out of it, and that's just amongst the types. So for the purposes of my conversation, I'm talking about digital being the way that we use digital technology. Now that's hardware, that's software, and the data that sits on it to deliver services in new and or improved ways. So from our perspective within Sussex Partnership, we had 5 things that we felt we really needed to do as quickly as possible when COVID hit us. First was to mobilise our workforce. We obviously have a lot of people. We've got over 6,000 staff within Sussex Partnership. We wanted to keep them as safe as possible while still maintaining a safe level of services for all our service users. So key to doing that was to make sure that as many people as possible could work from COVID secure areas. Now, for a lot of people, that meant working from home, but also it meant perhaps changing the clinical settings, so people wouldn't be working in the areas that they normally worked in. So we had one piece of work, which was to get our workforce as safe as we could while still being able to work as effectively as they could. We also stood up a 24/7 mental health line. So the hardware and software behind that to make sure that people could staff that phone line from the comfort of their own homes, that we had all the phone infrastructure in place so we could divert calls amongst people, both on site and off site. And of course, that we could make sure that they had access to all the appropriate systems that they needed in order to both be able to give appropriate advice, to refer people where appropriate, and also to access things like clinical records where necessary to get background information. We also thought that it was really important to maintain our Discovery College, which many people may know is a peer support learning facility, which is incredibly useful to our service users. And so although that's mainly done in person in the pre-COVID times, we wanted to make sure that was still maintained as a resource. So we put that together online, moved all our courses online. And then we looked at which of our services could be virtualized. So where could we move them away from face-to-face and into the digital arena? And obviously we deliver many services. It's not just one-to-one consultation. There's the learning, there is group sessions, there are workshops, and there's been the behind the scenes work away from clinical settings as well. And key amongst all of that was our virtual consultation. So pre-COVID, we had a small number of teams who were offering a very small number of virtual consultations. So we had the software in place, we had the policies and procedures, but actually adoption was thin on the ground and quite patchy across the trust. What we wanted to be able to do, we set this ourselves this as a goal right at the beginning of COVID, was we wanted to be able to make sure that every clinician should be able to offer a virtual consultation, and every service user or carer should be able to request one. And we wanted to do that right away across the board and across all our services. So we started off just using Attend Anywhere. We spun it up very quickly. There was a national offer, and we started using that for all consultations, both with service users and or their carers. We already had Skype within the trust for professional meetings. And very quickly, we realized that the combination of the two wasn't enough, simply because of the different interactions that we have with people. So we brought in a number of other products, GoToMeeting for group interventions, because obviously we have quite a rich pattern of group intervention and workshops that happen across the trust. And also Zoom, which we're now using Zoom Enterprise under pilot because of the functionality of things like breakout spaces, which weren't available within Attend Anywhere. And we've also tried to take a really flexible approach to using other apps where those solutions didn't fit what was needed on a clinical ground. So we've been guided by the clinical need and the service user preference, but also trying to make sure that in all of these, we're making sure that all the appropriate information governance and other security protocols are in place, because that is incredibly important to us. And so where we've used something novel, so for example, our dysphagia clinic, that's for people who are having trouble swallowing. Obviously you can't assess if somebody's having trouble swallowing in the middle of a Zoom call. So we use WhatsApp, so a carer can actually film somebody swallowing, so we can see the issues there from a remote session rather than having to have people come into a room together. If I look now in terms of Attend Anywhere, we had a rapid take-up and a fairly consistent take-up across the trust. Now, this is our cumulative numbers, and so I won't get too blown away by the actual numbers that we've run over the year, although that's way up over 55,000. But I think more to show here that it is a fairly level line showing that the use of Attend Anywhere has been consistent across that period from March to November. And also to flag our mild smugness at being the highest adopter of Attend Anywhere right the way across the NHS England. If we look at how those numbers actually break down, and apologies, this is a fairly small slide, but just to show the top bars here are showing the highest numbers of consultations, and the services that are primarily carrying out those video consultations are our primary care. So Health in Mind, Brighton and Hove Wellbeing Service, the partnership that we have with the YMCA, and then we're moving into CAMS. So Children and Young Adult Services are the next highest adopters. And I suppose some would say that isn't that inevitable because younger people are more likely to be digital adopters. But we didn't find that was necessarily the case. But throughout this, we've been really keen to not just throw technology to a problem and see whether it sticks. We wanted to make sure that we had some feedback, some fact-based analysis, so we could tell what was working, what wasn't working, and how we could then have a learning process so that we could see what we would transition into our day-to-day practices when we moved on into the post-COVID world. So we started off by having a very short survey sent to both our service users and the clinicians at the end of a virtual consultation setting. And this gave us some interesting information. So for a start, so I'm not going to go down into the small print here, but just concentrating here on the right-hand side of the screen. This is service user and carer experience, and you can see that on the whole, the majority of the experience has been green, which is agree for pale green, and strongly agree is the darker green. So service users were reporting that they had the appropriate equipment and space to be able to use a virtual appointment. Now, I think I must caution, as Leicester did, these were obviously the people having virtual appointments, so you would expect there to be a high bias there. But importantly, people felt that they were able to express their experiences, thoughts and feelings during the appointment. They felt they're being listened to and understood, and the clinician and service user reached the outcomes that they had intended to. I think just keep in mind that level of greenness there, and we'll look at the corresponding clinician survey, and you'll see, although still predominantly red for similar questions, we do have more on the neither agree or disagree, disagree or strongly disagree. Part of that was on the reliability of the software for the session, the ability to assess risk, engage with the service user, and to reach outcomes. So on the whole, we're finding that service users are reporting a more favourable experience than our clinicians. And so for us, that was incredibly helpful and is helping us to shape our service the way we go forward. We've backed all of this up with more formal research done with partners at the University of Sussex to make sure that we're really gathering what the experience has been like overall, and also what we can learn from going forward. And so in terms of learning from our experience, I think first of all, a key thing is that we need to be thinking about flexibility in use of virtual consultation. And whether it's used or not should very much be a dialogue and a decision made jointly between the service user and the clinician. What we've really definitely found is there is no blanket use virtual consultation for this category of interaction and not for that category of interaction. It is very much to be guided by the service user in conversation with the clinician. I think a second thing that we have been acutely conscious of throughout this period is the whole issue of digital exclusion. We do find that there is a strong correlation between members of our service user population and people who are tending to be digitally excluded. And so I think when we first started, we blithely said, okay, well, we'll put this in place. Anyone can take part as long as they've got a mobile phone. We found that that perhaps, while not being untrue, wasn't really an accurate reflection of the situation. And going forward, we know that we need to do a lot more work in terms of digital inclusion. And we're now adding that to our digital strategy for the future. We also had to think about the impact on our clinicians. For many of those who are used to working in a clinic setting where there is professional support around them, if they need a friendly ear to bounce ideas off or discuss problems, we were expecting people who were working remotely from their own home without that support structure. And some people were struggling. You know, your home is your safe space, and some people were having very challenging conversations without the backup of the support that they would have had at the office. So we learned quite early on that we really need to think about how we can support our clinicians more effectively, not just in terms of using the technology, but also that broader issue of well-being, professional support, and ensuring people were able to switch off within the home setting when they'd finished working. And then finally, in terms of learning from experience, I think, again, when we started, we were thinking about virtual consultation being a one-to-one thing. And that's where we focused our efforts at the beginning of COVID. What we've learned over the COVID period is how important group interventions also are to the therapeutic pathway that our service users are on. And so we have definitely realised how integral they are to the clinical offer, and come to the recognition that multiple solutions are needed. There is no one size fits all. And in developing solutions from a digital perspective, then we have to think about how we make sure that our clinicians have a full box of tools that they can use, and that they're feeling happy and confident in using those. But also that they have the skills to determine which is the best tool to be using, and that we then have the appropriate conversations with the service users as well to make sure that they're happy with the technology and with the approach that's been taken. So in terms of what's next, well, we're very much seeing this as the start of a journey. We've had some amazing successes. We've had some things which haven't worked so well. And we think right the way across the trust, we are trying to learn from the experience of COVID as a whole. And the digital element is forming an incredibly important part of that. So we're already looking at what our services will look like in the new normal. There are a number of work streams going in place as part of the wider ICS our sort of system offering. There are conversations going on there about how we redesign our services to meet the world of the future. And digital is very much at the heart of those conversations. And we're looking at what a blended offer might look like. So where digital is best, where face-to-face is best, where your good old landline is best, and how we can design services to incorporate all those elements, rather than being one or the other. We're looking across the wider health system and how we as a trust can feed into that based on our experience and the experience of our service users, and how we can start redesigning things at that level. So whether it is by giving people a what we call a patient portal, so people can actually access information from their care record, take that with them whichever service they happen to interact with, so that we can get rid of that sort of every time you hit a boundary of a service, you have to give people the information again, which is both a waste of time, it leads to inaccuracies, and it's a bad experience for people. So we want to look at how we can eliminate that. And as I touched on earlier, we're also looking at how we can make digital inclusion part of our digital strategy, both within the trust and within the wider ICS structure, so that we don't leave people behind or people feeling that they're having a second-rate experience. You know, we're all very clear that digital interventions, digital consulting is never, ever going to 100% replace the physical face-to-face meetings. We don't want that to happen. But we want people to have a choice. And at the moment with COVID, we're perhaps skewing too far on our emphasis towards digital interventions, but we don't want to go back to 100% face-to-face following COVID. So we recognise that in order to make those options available to everyone, we've also got to think about digital inclusion. And so that will be part of our work going forward. So I think that's a whistle stop about what SPFT have been doing with digital over the COVID period. Obviously, it's a work in progress, and we are very much mindful that The pressure of COVID has made us make some quite quick decisions. We need to revisit those, and we need to find out what works for our wider communities. So I'm hoping that as we move into the breakout sessions, you'll also feel able to tell me about what's worked and what hasn't worked, where you are, and how we can factor that into our thinking. Thank you.
Okay, thank you very much, Beth. Two great and interesting presentations. And I want to move on quickly to our third presentation, which is from the voluntary and community sector. So over to you, Nathan. And Nathan, we'll aim to finish at about 10:02, so I'll give you a little bit of extra time. And we'll go a little bit late into the breakout rooms, but I want to make sure that everyone hears and sees your presentation as well. Okay, over to you.
Thanks, David, and hello, everybody. I'm Nathan. I'm team manager for the Thinking Well service for Southdown. The service is run in partnership with Sussex Partnership Foundation Trust. And I'm going to give my apologies because on the version I submitted to Rebecca, I didn't add the SPFT logo to the template, which is not a good example of partnership working, so apologies there. Yeah, I want to just share an example of our service, try and quickly define what our service is as whistle-stop as possible, and then just answer a few questions that highlight our experience of how we've adapted in the current climate and what that process has been like. We have seen a lot of success, but it's not a straightforward process as people have touched upon, and it's certainly not over and done with. There's a lot more work to be done. So what is Thinking Well? We're a group-based service that support people to manage their emotional intensity, and we're commissioned to work with the highest costing service users across East Sussex. So think people that have regular A&E attendances, hospital admissions, frequently struggle with suicidal ideation. We are there to offer a group-based service to support people to better manage their emotional intensity. And our focus is on supporting members to develop skills to manage this and to offer a reparative experience in a safe group-based environment by creating a sense of safety and gradually offering agency through working in collaboration and empowering our members. The service model is not one-to-one based in any way. We focus on being mindful of attachment, and we're transparent with members about this process. We want members to become attached to our service and not to individual members of the team, and we explain the rationale behind that process and get our members to kind of sign up to that thinking with us. And we aim to work closely with other services, which is why we're all here today. And I can't stress enough how crucial working closely with other services is, because if we didn't have the links we have established with other services and that we're continuing to build, we wouldn't have been able to achieve some of the things that we have that we're proud to share today. So what were the initial challenges? Well, our model was hit really hard by the initial lockdown, as we're entirely group-based. We have about 25 active members per area at any given time, and we work over 3 localities. So 3 different buildings that got shut down, all those buildings with a slightly different setup. And we didn't have a virtual model previously established. It was all about attending the building, working with us in that live environment. So we didn't have a virtual environment to default to. So it was very much a case of having to think on our feet and create one. And of course, because of this, we really value creating a sense of community and talk openly about connection and safety. And this is something that was really threatened by the pandemic, because people were losing something that was a predictable part of their routine, a predictable part of their care. And risking a sense of segregation, and in the sense of that sense of creating a therapeutic community and being part of a social experience with other people that have gone through incredibly challenging and traumatic experiences. So the first key question is how have we dealt with that process in terms of expectations and preferences? And we have a culture where we have as much honesty and transparency as possible, while of course being very mindful of boundaries and not wanting to jeopardize a kind of containing presence. And what I mean around this is we're transparent with the community about there needing to be a transitionary process. We've been honest about the challenges from our perspective as a team, and we've tried to look at it whilst being very mindful of the service itself, we've also tried to look at this being, you know, a shared human experience, really. This pandemic is such an unprecedented thing, and thinking about how we kind of work together to ensure that our support can continue. Clear communication has been absolutely pivotal part of this in terms of explaining why we've made certain decisions, such as initially going to a phone support model until we could get our virtual groups established online, which is what we have segued into. Developing and maintaining communication channels has been absolutely crucial in offering a sense of containment. And we've done that through things like a virtual newsletter, which we sent out to the community on a weekly basis, and through our virtual timetable, which gives us clear an idea as possible of what groups are going to be offered on each week and how those groups can be accessed. A core point that's come up today already is how do we help people to cope with that transition and with digital disadvantage. So we offered technological support sessions with members, and this was a case of people that were very apprehensive, understandably, of going from in-person model to a virtual model, thinking about what that looks like and helping people to feel able to take that leap with us. So in some cases, people were coming to us for very practical support sessions, and it was about, this is what this button does on Zoom, this is how you get your camera on, this is how you mute yourself when you're not talking. But some of this was about people being able to have a chance to get a feel for what this space is. What does it feel like to talk to you virtually? Does this feel safe? Does this feel something I can participate in? And by having a space where we could sit down with people, sit down online with people and process those difficulties, we, you know, we feel we've helped to reduce anxiety for when people then make the leap to join in a group, and being part of that with a community and with other people. Simplifying our approach wherever possible. You know, this has been a huge transitionary process and will have been a challenging process for our members in a time of huge anxiety to begin with. So we've tried to avoid multiple digital mediums. And what I mean by this is there's so many different online platforms at the moment. And it took us a while to have a stabilized platform where we could do our community and clinical groups on. As Beth touched upon, there is now the clinical variant of Zoom, which is what we've used as now a standardized process for any group that we're offering. If we're doing a review, thinking well-based review with other people involved in a member's care, such as lead practitioners, we will try and do that over Zoom as well, so that it's a very predictable model and channel that people are engaging in. Identifying members at risk of being cut off from virtual society. This has, of course, been a huge one as well. We have 70 members on our caseload, and through working with other people involved in that member's care and thinking and, you know, speaking openly and directly with members about their needs, we have only had 2 members out of our current 70 active that have not engaged in a single virtual group. And in those that have not engaged in that virtual group, we have been aware of and still inputted into what support they are still accessing, that gives them some sense of containment, and agreed what that might mean in terms of their future with thinking well. We were made aware of technological grants that became available, and through liaising with those members that were struggling to engage and lead practitioners, etc., we were able to help get some members funding to join us in the online realm. And then, as I say, the intimidation and the sense of the emotional barrier and of, you know, joining a new virtual society, looking at how we work through those barriers as well, and asking members what they need, because it's really, really important to ask that question. And often members might be really struggling, but they can still give very informed answers about what that struggle entails and what they need to get through that with us. So really not just assuming what members are going through, really getting that from the heart of them through conversations. And how are we shaping up for the future? So, you know, the journey's not done. We've got a long way to go. What's been touched upon is the emphasis on online tools at the moment and what that means going forward. And I agree with kind of comments that, you know, this is not going to be a regression after the pandemic is over, where we just go back to the exact model we had before. We will absolutely be going back to face-to-face work and working closely with our community, because we know how important face-to-face working is. And we've acknowledged as a community that this does not replace the therapeutic impact of face-to-face work. However, some groups have worked exceptionally well in an online format and have given us ways for members to so to come together as a community from different localities, which was something unprecedented before this pandemic. So Bexhill, Eastbourne, Lewis members have been able to come together and support each other as a collective in a way that just was not feasible before. And members have reported on how powerful that experience has been for them and how impressed they've been with that. So it's not about just going back to normal. It's thinking about what have we learned from this and what have we added to our toolkit that can continue to persist when we go back to more standard working, if you like. A key point, I think, for me about the virtual meetings is it's offered a new layer of graded exposure that we didn't previously have. So thinking about how difficult it can be for members with our diagnosis to form a secure attachment and experience a sense of safety with the service, it might feel absolutely terrifying coming and meeting a bunch of new strangers and being part of a new service model in person straight away. So by having a virtual avenue where we can meet in a 2-to-1 session, for example, and get to know somebody, that might be the start of a therapeutic connection that makes it then feel safer to take that leap into joining our in-person community. And it offers different mediums for which to help people make that gradual leap. And in terms of new tools, 2 new tools that have been really good for us are the creation of webinars, which means, you know, if you miss Thinking Well 1 week now because of another commitment or because you've had a bad time, you can still catch up on that content. You can see what discussion took place. You can look at the homework and ask questions through our phone line if you want to get stuck into that exercise. We've also have a new tool called the Box, which is very similar to Dropbox, as the name would allude, and it has become a digital resource where we have a dedicated link for our members. And our members in their own time can access a lot of the material that we would go through in the groups and in person or after the group has run. If you want to revisit that material in your own time, because most of our members only access us a day and a half a week, you still have a connection to Thinking Well this way. You can still look at that material and, you know, you can come back to us with questions. It really encourages that sense of agency in terms of what people can do outside of the service to keep working on their recovery, but with that option to still come back to us when they get stuck. Because, you know, recovery is a challenge and involves a lot of ups and downs, but these have been really useful tools that we will continue to have and promote as we return to face-to-face working. And managing expectations is absolutely crucial. And what I mean by this is it can be so tempting to, when offering reassurance, to give false promises, and it is such a trap in terms of like deadlines and dates and expectations. And when we've not known what a timeline looks like in terms of going back to buildings, in terms of when this pandemic will be truly done, we've been honest about that, and we've gone, you know, we don't know yet, and we've looked at an option of taking it a day at a time. We will convey information in terms of dates and clear expectations when we know we can uphold those, because we want to ensure that that sense of trust remains, and we want to be transparent about barriers. So when we've had barriers to access in the buildings for health and safety reasons, and for, you know, very important reasons for team well-being and safety of the entire community, we've been transparent about why there are those delays. And that doesn't mean dismissing frustration. It means acknowledging frustration, and that we recognize that this is a difficult process, but this is our rationale. This is why we're taking this approach. And we want to hear from you about how you're finding that process, making sure people have a voice, and not just in that kind of tick box way in terms of working kind of collaboratively with members, because it can feel sometimes that it's a bit of a gesture, and I think members really see through that, but really having member input at the heart of it, because members have been able to offer some really creative perspectives that I think if we were in our own team bubble, we wouldn't have maybe come to our own conclusion on. And we have forums such as a service development forum and committee meetings where members from the community meet with the team, and we share where the service is at, or we share what our dilemmas are as a team. And we get member input on how we can take those issues forward and update members on what that process looks like. I'm very mindful of time, so I think that's as far as I can go for now, but I hope that was a helpful overview.
Thank you ever so much, Nathan, and a really positive and creative message to finish with, and it's really about service improvement in the face of adversity, and that's really fantastic. Just before we go into the breakout groups, just to say the kind of the sort of the so what element in today. So what with all this information and new activity around digital? Well, we've had a request from the Mental Health Collaborative in the Sussex Integrated Care System, and from Adam Doyle, the Chief Executive of the NHS in Sussex, for us to come up with 3 or 4 things that we think are really important next steps in terms of creating digital solutions and digital options into the future. So that's the main aim in the individual forums that we're now going into. And just a reminder, please put in the chat if you haven't already selected a breakout group, or if you want to change your breakout group. And at this point, I'll hand over to Rebecca, who'll hopefully magically put us all into our place-based groups.
You should all be invited. Katie, what room did you want to... You're muted.
West Sussex.
West Sussex, certainly.
Yeah.
There you are. Martin? Is Martin there?
Can I change to Brighton? Is that okay? Because I think I'm down to the east.
Hello? Martin or Sue?
It's Martin.
Hi. Yeah, could I go into Brighton, please?
Both of you into Brighton?
Please.
Yep. There we are. Sophie, are you okay?
Of nuance put onto that, haven't we, from other organizations and other pieces of work, including a paper-based survey rather than an online survey that involved a couple of thousand people across Sussex. Lester, could you say anything about that?
Sorry, which survey are you referring to, David? So
the East Sussex survey.
Oh, sorry, yeah. I mean, the East Sussex survey was covered some of the same questions as we covered in our survey across Sussex. They had a separate sample of about 900 young people and about 1,000 or so adults. Most of their survey was actually focused on, because it was administered at an early time in the pandemic, much of the questions was on things like, sources of information and clarification of the messages, etc. But they did have a few questions towards the end on digital or preferences for appointments in the future, with digital mentioned as one of the options. But to be frank, I don't think it covered the same depth as we covered in our survey about future preferences. But can I just use the opportunity just to add a couple of things to that, while I'm speaking, that in relation to, I mentioned at the end of my conversation about this briefing report that I'm constructing, It's proving to be completely quite a complex area. But there's two things that struck me really quickly when we are discussing digital solutions. One is that digital exclusion or inclusion is clearly not a binary concept. It very much operates over a spectrum, from those people that have, no use, no motivation, to those people that have a basic level of skills, but not sufficient skills for them to be perhaps confident to arrange an online appointment, through to those people that have, fully adept to digital solutions. So it really operates over a spectrum. So I don't think we shouldn't assume that digital exclusion is just people that have no access, no motivation. It's more complex than that. Operates over a spectrum. And the other thing that I've noticed, which is, again, it's sort of kind of obvious, but when you read it in the data, it's really significant, is that there's quite a lot of focus on giving people access, connectivity, free Wi-Fi, tablets, etc. But by far the biggest reason that people are not or are digitally excluded is lack of motivation. They don't see that the internet or being online can actually offer any potential benefits for them. So that's why when people are looking to promote digital inclusion, that motivational aspect has to be tackled. And one of the key ways that is done is introducing digital in an arena where they can see the benefits. So the classic example would be that if you're an arts and crafts course or a bird watching course or whatever, you can show them, look at all these fantastic sort of crafts you could make. So they get that motivational angle from that point. And that's a crucial stepping stone for them potentially being able to access digital services in health and social care. So that's just two observations that have come out of that evidence.
Lester, was there an age range that barrier was more significant in terms of motivation, or was it just across the board?
Well, I mean, the early evidence is not surprising. It's the older people, and also the links, bear in mind, between digital disadvantage and vulnerability is very strong. So those people that are isolated, various other measures of disadvantage is very much correlated with digital exclusion.
Yeah, it's interesting.
Okay, do other folks have comments and thoughts on that?
Hi, it's Rachel from MA. So we work with people with additional needs, aged 14 to 25, as well as their parent carers. And we've, I guess, seen some similar things that people have been talking about this morning, but certainly with a large cohort of our young people, we're seeing they're definitely ones that are asking for the return to face-to-face, and we've been able to keep a lot of their activity groups going face-to-face, thankfully, in recent times. And their feedback about online is quite often about trust and lack of trust and feeling exposed to bullying potential, and not really necessarily trusting the information that they're reading or not knowing where to source it. So I was interested, Lester, in your data, whether you had any correlation between age and disability in your findings, or whether you didn't get enough of a sample from the younger disabled cohort, and if anybody else has seen similar. Thank you.
Yeah, we didn't. We looked at age and disability as separate entities in that sense. Even though the majority of our sample were, not the majority, a high proportion of people reported disability, because of the age of our sample was so skewed really towards an older age group, it's very difficult to look at the patterns between disability and younger age groups. I don't know if Gemma, there was anything from the Young Health Watch survey of any relevance?
There wasn't anything significant around that we pulled out. It was more focusing on the barriers and the solutions in the end, really. Young people were quite up for adding in free text around how they felt those barriers could be removed, rather than there being any significance around disability from the young people that we spoke to. But we're doing a follow-on in January. So it'd be really interesting to see what comes out of that in terms of different demographics and intersectionality. That'd be really good.
That's really interesting, Gemma. It'd be great to ask in that follow-on whether the young people you're in touch with have got additional needs, maybe.
Yeah, we did ask, but there wasn't a significant, there weren't barriers that related necessarily to that group of respondents. But yeah, we're widening that project now. So yeah, we'll definitely ask.
Can I also throw in a question about sorry, it was going on to something Nathan said. He's not in this group, is he? But he mentioned using or introducing the box. Did anybody pick up any more detail about how they did that? Because I really like the idea of having this kind of virtual space online for specific resources. I just wondered if anybody else had, other than just sort of general website content, whether anybody else had developed a sort of membership area for additional content. If that was something anybody else was looking at.
Rachel, Nathan described to me in detail before the forum how they did that, and it was really interesting and engaging. So what I'm going to do is, and I'll do this for any questions to any of the speakers that aren't in the room, I'll make sure that we actually record them answering your question, and then we'll put the answers as videos onto the Sector Connector web page. Rather than giving people long, boring written answers, let's try and do it a little bit with digital imagination. I think the other thing out of what you said, Rich, that really struck me was, I think we're only going to get the nuance about folks with, I think we're only going to get the nuance with folks with particular kind of sets of needs by going to organizations like yours to help us make the link. I don't think general broad-based surveys are really going to do the trick on that. So I think helping the system, the NHS system, local authority, public health, mental health system, to better understand digital and to better progress things with digital. I think there's going to be something about building the link between the decision makers, people like Beth, who head up big chunks of this within the NHS, and organizations like yours, because I'm not sure the link is there at the minute. Hi, Tina.
Hi,
from Beltree, one of my favorite voluntary organizations in Brighton. These guys are amazing, by the way. If you haven't already, go to their website. Really inspiring use of music therapy, including lots of online stuff, Tina.
That's right, yeah. There's the whole resource online. People can access videos to support wellbeing through singing-based activities or drumming-based activities, or just guided musical involvement generally for groups or individuals. So yeah, we've been getting a really good response to that. Thanks, David. My question was, could people share what has been working well for people with disabilities and mental health issues? Because the survey said that people with disabilities find it harder to access and engage in those services, but they don't find it impossible, and there has been some successful work going on. We've been continuing work online with some of our clients, most of whom we had a relationship with before the lockdown, and we transferred it online, so the relationship was already there. And I think for people with disabilities, that's really helped. But we've also started initiating new work online recently. And we found the support of carers really important to help that happen. So perhaps some work could be done with the carers of people with disabilities to help them understand how this work can be helpful. Different types of work can help online. I'm just interested to hear what actually has been happening and working well in the area.
Any folks want to come in and help Tina?
I don't mind. And then just to start off, totally echo or resonates what you've just said, Tina. Certainly it's much easier where you've got an established relationship with somebody, whether that's the carer or the young person, in our case, with an additional need. We've found those that are more likely to sort of adapt to virtual, online, digital groups are those that we've already got a trusted relationship with, and but we've been doing those groups in much smaller numbers, so that maybe there's only 6 faces on a screen that young person needs to kind of be able to, or have to look at. Also depends if they're using a phone, doesn't it, or a tablet or a computer, because if you're on a phone, I think you can only see a few people at a time. So kind of trying to sort of coach somebody through having to swipe all the time or have a different gallery view or whatever can be. But absolutely agree with what you're saying about the carer, and yeah, we're absolutely working with carers to be there supporting their child or young person to do that. But yeah, much more tricky picture, isn't it, when you're working with trying to build a new relationship with somebody that you've not actually met before. And I'd be really interested to know if anybody's cracked that one.
Yeah, I mean, we've found that the people who've initiated the work online have been the ones who are completely socially isolating due to health risks, and they can't access anything. So it's a case of it being better than nothing. So that they start off thinking it's you know, better than nothing, but actually it can go incredibly well online if you've got that support and connection, and that the carer facilitates what's needed to help the session work. Yeah.
Observations from any other folks?
I think it's important as well to acknowledge that a lot of people don't receive the care and support that they need as disabled people, and that was the case even before additional restrictions and issues with care. So whether it's difficulties in recruitment, difficulties in social care assessments and entitlements, a lot of disabled people don't have the support that they need. And if they do have a really small amount of support hours, that's probably going to go on personal care and shopping and essentials rather than support for appointments or wellbeing activities. So I think that's quite significant that we found that a lot of people who maybe would have been able to come to an in-person thing independently because we support with travel, because they know how to do it. Sorry, I'm echoing somewhere. That isn't the case because they do need support to get online, or there's so much else going on that it's not a priority right now. So I think that's going to be difficult. I think my other related point was about, I've forgotten it. Sorry, I might come back.
That's great. Harriet, just remind folks which organisation you're with.
I work for Scope. So we're disability. We're working in Brighton with people aged 12 to 65 and unpaid carers and parent carers of any age.
Hi, David, it's Sophie. Can I come in with something?
Yeah, please.
Yeah. So, I'm Sophie, and I'm on the board of Health Watch, but I also am one of the trustees for Possibility People that works with all disabilities across Brighton, Hove and East Sussex. So yeah, I think this sort of question about disabled people and digital, I think there are 2 points. So one of the things that I was going to say is that I think sort of historically and still now we see that disabilities come in so many different shapes and sizes, access requirements, that's not even bringing into consideration people's choice as to how they want to do things. So I do think that it's very much, it sort of comes down to an individual's ability and choice. And that one of the best ways of enabling that is by having some sort of rapport with the patient or service user to begin with, because then you can actually ask them what their needs are and enable them to express it. So that was sort of one point. And I think the second point was really just to give an example of how digital working has actually really helped me, whereas I never thought it would do, which is that I've got quite complex needs, and actually using video has really helped me recently in a way that I'd like to continue doing in the future. Because when I go and visit my GP, if I need to show them, I don't know, a sore on my foot at the GP's practice, I don't have the facilities to get me onto the couch and transfer and so on. So to be able to do that in my own sort of surroundings where I have those facilities makes an enormous amount of difference to both me and my carers.
That's fantastic, Sophie. And
does that, yeah.
Sorry, you were going on to say?
No, it's just saying, is that helpful as an example?
I mean, I think it's very helpful as an example, because it what really jumped out at me was when you talked about individual and personal care.
Yeah.
And of course,
yeah,
for many decades we talked about trying to promote personal care, and then suddenly everything went COVID and everything went digital, and the kind of mass solutions to access to GPs, access to mental health services, and whatever. And maybe one of the key things we have to feed back to decision makers and the folks at the top of digital planning is, how are you going to factor in personalized care into a redesigned NHS and redesigned social care system and redesigned mental health care system?
Yeah. And I think you're right, David. And I think, we know that people with disabilities often are struggling to fit in with, a lot of sort of systems and practical life around them anyway. So if they then have that additional struggle when they're accessing what is often their very basic health needs, then it's we just need to be very careful that doesn't happen.
Okay. In terms of us trying to get at a few key points that we can kind of put in front of decision makers, could I just throw a question out there and ask, in the work that you're all doing, what are the things that have struck you where you thought, if I could just get someone that had the resources, had the money, had the position to be able to change things in the NHS or change things in mental health services, what would you want them to do? 1, 2, 3. What's your shopping list for getting things changed?
Can I say something?
Yeah,
I'm
sure,
Dawn. I'm from Brighton, Hove, Speak Out. I mean, I think it would be that things need to be needs-based and personalised. That one-size services don't fit all. That's been mentioned a few times today. I would have agreed. I was going to say something along the lines of what Sophie said, basically, which is obviously I work with people with learning disabilities, and I constantly hear people talking about disabilities, but the challenges that are posed to people with learning disabilities are often a completely different set of challenges than those faced by other people with other sorts of disabilities. So it doesn't sort of cover, it doesn't often, even though people with disabilities are being considered, often that doesn't mean people with learning disabilities are being considered. So for me, it would be that things need to be needs-based and person-centered.
I certainly think it's always worth repeating that and reminding folks who may not have the face-to-face or day-to-day contact with people that many people in this room will have had in the past and will have in the future. There's lots of people who make decisions in this great big system that actually don't have a lot of contact with service users or patients.
I was going to say, to facilitate what Dawn said, it's absolutely about co-production, isn't it? And what you've said, David, the service user being at the heart of designing those services and shaping them to be what they need them to be.
So the folks, I mean, in terms of the services are being redesigned in front of our eyes, and we heard from Beth about the way in which statutory services had adapted themselves. We heard from Nathan about a way in which one voluntary sector organisation had adapted. Do folks in the room feel that they've got a route to decision makers, to statutory mental health services, to be able to express what your preferences and expectations are, and what the preferences and expectations are of your service users, in terms of the services that are being redesigned in front of us?
I'll just say my
Hi,
2 pennies worth about the arts therapies, because I don't really feel that they're being embraced as widely as I'm told they are. I'm told that there is music therapy and arts therapy being provided, but I don't see it. I don't see it, and I'm not sure how open and aware people are of how non-verbal interventions can draw people into the services in a different way, and how that needs to be valued. Yeah, that's very subjective, obviously, but yeah, I'd like to see the arts therapies being incorporated more actively.
Any other thoughts or contributions around that?
I guess it's not on that point, but we have quite good partnerships and into relevant statutory decision makers, but it's just incredibly difficult time at the moment, isn't it, with COVID distracting absolutely everything. So we've got a situation where young people are waiting 2 years for an autism diagnosis, 3 years if you're trying to get a diagnosis for ADHD at the minute. You know, really horrendous wait times for assessments that are being impacted by you know, everything else and other priorities and whatnot. And I think we're clear, decision makers are clear what needs to happen. It's just the capacity of people and the system to progress the thinking and to make those things better, isn't it? It's just an incredibly difficult time.
Yeah. Hi, Charlotte.
Hi there. If I just like to add on from Tina and Rachel, I mean, waiting times are absolutely problematic and continue to escalate and grow. Just going on from Tina, the creative therapies, I absolutely agree on that, and would just like to say that I'm from Brighton Women's Centre. I manage the therapy service there. Part of our aim is to be able to provide creative therapies alongside the talking therapy. So we have a therapy service, very consciously called the therapy service and not a counselling service, to incorporate such therapists. At the moment, we have dance movement psychotherapists alongside the talking therapy. So I just wanted to add that there, and just say absolutely would welcome more music therapists or art therapists alongside that, and to develop a referral pathway, perhaps, Tina, or to other people.
Thanks. I'll message you.
That's fantastic. This is the kind of creative link that Sector Connector was set up to facilitate. So it's music to my ears. Any other thoughts around how we might be able to improve the link between service users, members of the public with niche requirements and very personal needs, and getting messages to decision makers about what would be helpful? I'm certainly picking up a few things, but I'm just wondering, and we've got about 5 minutes left, so if there are other thoughts, it'd be great to have them shared now.
Hi, I'm Nia at Together Co, Social Prescribing. So I think something that I'm definitely hearing and experiencing is, as was touched on earlier, that kind of lack of motivation to engage digitally is a really difficult thing to break down. And I think a huge part of that is that no one has the time to give the type and level of support that people need to either improve that motivation or to improve their knowledge. And we know that, you know, for example, Digital Brighton and Hove exists, but I think there's need that is not being identified as early or by maybe the right people as it could or should be, that then causes a bigger divide. And I think it's one of those things where it's no one's fault. It is time and resources, as so often the case is. And I know Lester said, you know, a way to introduce digital tools is to do so in an arena that clearly shows the benefit. But I think that without sufficient support and prompting, people never get to a point where they can engage with that arena. And so something there around having people who can give that time, give that space to try it out in a way that is maybe not so linked with a specific service providing a specific thing.
That's interesting, isn't it, Nia? Because folks with emotional and mental health issues don't always know where to go or what to ask for. And certainly also the case for folks with disabilities, in my experience. So there's something there about the omnipresence of a digital offer, but with kind of no wrong front door, but also eventually us pulling off the trick of making that service personalized as well. And that sounds like a massive set of challenges, but good challenges. And any other thoughts, guys?
Can I say something?
Yeah, sure.
Yeah, I just wanted to say just really briefly, actually, it's sort of from what everyone's been saying, I think the 2 points that are really coming out to me are that obviously we need, you know, there are decisions that need to be made and things put in place, but there needs to be a certain amount of flexibility, which will reflect that individuals' needs. And that comes across, you know, mental health and disability. And I think the other thing is, for everyone, it's that ability for change, because sometimes you get bracketed. So just because you have certain needs now, or you tried something, it might not work for you in a year's time.
Yeah.
And that needs to be possible, however we set things up.
Yeah, I think that's also really important, Sophie, the whole thing about considering this issue over time, because the pace of change around this has been absolutely frantic.
Yeah.
I can't believe that last February was just last February.
Yeah.
And, you know, initially we had the whole thing about, oh, let's go out and find out what people's experiences are under COVID. And it struck us very, very early on in Health Watch that actually that was going to be a very temporary window. We needed to move on really quickly to what people's expectations and preferences would be for when we got out of COVID. But even that is starting to feel a bit like old hat. I've been really struck by the discussion this morning around, you know, personalization. How do we take this into the future? The kinds of relationships that need to happen, the kind of in-depth reach into specialist areas of need that's going to have to go on to properly personalize services in the future, and also to make sure that the service user voice actually leads change. I'm just going to give one last chance for folks to say things before I wrap stuff up. Lester, I think you were kind of indicating you were going to come in.
Yeah, maybe a bit old hat now, a bit out of context. But when we were talking about the learning about digital in a sort of safe environment, I think one thing I found out in reading around the subject is the great potential for peer support. So that can be quite formalized in terms of digital champions, but more likely and perhaps more successfully would be through working with families, friends. I'm aware of some intergenerational work that was going on in care homes, younger people going in and talking to people in care homes. I don't think that's obviously happening right now. But also working with professionals in terms of frontline staff at GP surgeries, etc., or carers, people that can impart that knowledge in a safe, less formal kind of, let's all go to the arts, crafts and learn about digital. So I think that is an option, certainly towards what's happening now and can continue in the future, I think.
Absolutely. Thanks, Lester. And I see Stephen in the Stephen Cribb in the chat has made a really good point, and a lovely positive note perhaps for us as we wrap up. Stephen, come in and share with people.
Yeah, hi everybody. So I'm practice manager at Links Road Surgery in Portslade. And really the point was just simply, can we imagine for a moment what the last 9 months would have looked like if we hadn't had any digital options? It has been transformational. It has been a necessity as a mother of invention. It's very easy to look at digital and people who can't access it, etc., through perhaps a slightly negative prism. But I actually think that digital has actually saved our bacon in this last 9 months. So for me, I'd like to see a large element of digital connection between patients and healthcare services and support becoming a real main element of the offer, not the only element. Clearly cases where face-to-face is necessary and face-to-face is better. But I actually think that digital has opened up opportunities that we probably never even thought possible. So the ask now is that we actually make digital even better. And obviously we try to make it viable for more people. I mean, clearly some people it's not really viable for. So that probably won't change permanently, but let's build on some positives. Thank you.
Couldn't agree more, Stephen. I think the possibilities and the reality is truly transformational. I know that yesterday I went and had a B12 injection that was arranged digitally. Tomorrow I'm going for a bunch of tests about stuff, and I've had online consultations in the last couple of months with a number of nurses and other clinicians for my own health, and that's been a lot easier and a lot more convenient than driving over to Chichester for an appointment or even going to my GP surgery. I think we've all experienced something of that sort. Listen, folks, can I just thank everyone for joining us this morning and reassure folks about 2 or 3 things. First of all, we will have a follow-up on this. We'll email people out with links to the Sector Connector webpage, where we do hope to be able to answer any questions that have been left in the various chats. And of course, Sector Connector is now, I guess, a permanent feature of the Sussex scene. We've got a plan for just about the next year ahead, and future forums are going to focus on resources and money in mental health, and who's got the money, who's allocating it, where's it going to, and why am I not getting any of it? Then we're going to do another forum later in the next year on Foundations for Our Future. So that's the Children and Young People Sussex-wide review of emotional and mental health services. And we've got another forum planned even later next year, looking at the redesign of community mental health services. And that will also, I guess, be very relevant to primary care networks, primary care, and those links. So we welcome you this morning, and we'll welcome you folks to other sector connected forums in the future. And we'll also share with everyone, when we've had a bit of a think and sorted out our big asks for redesigning and rolling out digital in the future, we'll share all of those with folks as well, and hopefully carry this on as a conversation. If you've got asks or ideas for future forums, or if you've got ideas for how we can creatively link together groups of people around specific issues, it doesn't have to wait until forums. We've got lots of work that's going on between the different forums. Then please email me or Rebecca or Lester at Healthwatch, Brighton and Hove, and let's keep talking about it all. Once again, folks, thanks very much for coming this morning. I hope you've all found it helpful, and stay safe. Bye.